Thank you so much, Adrian. I would like to thank also Rupa as well as Cyrex Laboratories for giving me this opportunity to present in this class. So today we are going to learn about very brand new subject, which has been in the immunology literature during past 3 to 5 years. And that is called systems immunology. So we are going to learn more about systems immunology. What is it? Then we'll learn more about mechanism of humoral and cell-mediated immune system that contributes abnormalities. The humoral and cellular immune system contribute to autoimmune diseases. What is the role of exposomes, such as food, toxic chemicals, and pathogens on the gut and blood-brain barriers, which is the gateway to autoimmunity and neuroautoimmunity. And finally, I'm going to emphasize the importance of essential barrier panel and comprehensive lymphocyte map for when a patient for the first time is coming into your office and you don't know where to start. I highly recommend to start with essential barrier panel and LMAP, because information obtained from these two tests can give vital, interpretable information, which is part of the systems immunology testing. So with that introduction, let's go as that immune system is a very complex system. It is involved almost with every single disease in the body, but some of them are in here: inflammation, autoimmunity, immune deficiencies, cardiovascular disease and autoimmunity, transplantation, organ transplantation and rejection, tissue and organ repair, regenerative medicine, pain management, cancer, neuroinflammation, neurodegeneration, and of course, because the exposome factors affects the immune system that may result in some of these disorders, I'm emphasizing the role of food, toxic chemicals, and pathogens in some of these immune disorders. As the immune system in people is as diverse as height, beauty, intelligence, and other human features. And that is because our genomes, our lifestyles, and our exposomes are different from each other. And therefore, each one of us, we are going to have different immune prints or immunotype. So if each one of us, we have different immunotype, then I'm asking, when three different individuals with three different immunotypes get infected with COVID-19 or other pathogens and get admitted to the hospital, all these three individuals, one in the middle, which is the sweet spot, balanced immune system, one with hyperactivation of the immune system, which is more prone to autoimmunity, and the third one with hypoactivation of the immune system, meaning immune deficiencies. These three were and are going to be treated with the same medication, dexamethasone, or other medication which cause immune suppression. In this particular case, maybe the one with hyperactivation of the immune system is going to enjoy from that medication. But the one with complete balanced immune system, I don't think we need to do anything, because the immune system is going to take care of the virus. And furthermore, the one with hypoactivation of the immune system, If we are going to suppress further the immune system, there is no doubt there is a potential for harm in this individual. So here we see, if we take those three individuals, one in immune balance, one with too much or hyperactivation of the immune system, and one with too low or too little or hypoactivation of the immune system, and we'll measure biomarkers of humoral and cell-mediated immunity, we are going to see a pattern. And the pattern is that the one with too little immune system or hypoactivation of the immune system, if, for example, we look at total immunoglobulins, low, 410. The normal starts from somewhere around 600 to all the way to 1500. So this is the sweet range. And then there is one with hyperactivation of the immune system, higher levels of total immunoglobulins. The same thing when we look at secretory IgA, major components of mucosal immune system. The one with low IgG, most probably also they are going to have low secretory IgA, and the one in the middle, also they are going to enjoy from the right range of secretory IgA, and the one with hyperactivation of the immune system, high levels of secretory IgA. When we look at cytokines such as TNF alpha, the one with hypoactivation of the immune system, low TNF alpha, the one with immune balance, normal level of TNF alpha, and the one with hyperactivation of the immune system, too much TNF alpha. So those are the biomarkers of humoral immunity. And then when we look at cell-mediated immunity, for example, just total lymphocytes, we see a low number of lymphocytes in those with hypoactive immune system, low number of B cells, low CD4, CD8 ratio, low natural killer cells. That shows that there is connection between humoral and cell-mediated immunity. When one of them is affected, the other will be affected automatically. And the reason is because, for example, total immunoglobulin or secretory IgA, if the B cells are low, the B cells are going to produce these antibodies. And therefore, because the numbers are low, probability of having low total IgG or secretory IgA also is very high. So when we look at the one with too much or hyperactivation of the immune system, when the number of B cells are high, they are going to produce more antibodies, resulting in high level of total immunoglobulins or secretory IgA. So the bottom line is here we see a pattern, identifiable pattern that is very important to look at, which is, by the way, this is part of the systems immunology. What is systems immunology? Strategies for measuring a broad range of immunological assays as a means of discovering previously unknown relationships and phenomena, and as a powerful way of understanding the immune system as a whole. So I would like you to remember that systems immunology is about understanding the immune system as a whole. We cannot separate humoral immunity from cell-mediated immunity because they're interconnected with each other. Very elegantly, this issue of systems immunology was published in the Journal of Trends in Immunology in August 2023. Let's read the title of this article: Making Human Immune System More Interpretable Through Systems Immunology. And I'm going to add to that, this is another quote taken from the same article: measuring a broad range of immunological assays, making human immune systems more interpretable through systems immunology. I'm going to repeat this statement again and again. So one of the major goals of systems immunology is to increase the predictability of the immune system, thus contributing to the advancement of personalized medicine and development of clinical therapies. For me, this is the picture of systems immunology. Everything is connected and interconnected. In the middle, humoral immunity, cell-mediated immunity or cellular immunity, mucosal immunity, of course, innate and adaptive immune system, and all the cells, molecules, organs that are associated with proper humoral and cell-mediated immune function. All of these are interconnected. It is very well established that, I'll give you a classical example. If number of neutrophils are elevated in the blood, automatically the neutrophils affect the number of natural killer cells. So high neutrophils correlates with low natural killer cells. And we know that when number of B cells are low, automatically number of T cells going to be high. Or when the number of CD4s are high or low, the number of CD8 are going to be low or high. And the same thing applies to Th1, Th2, regulatory T cells, and other cells involved in the immune system. Clinically speaking, we need to look at both humoral and cell-mediated immunity. Humoral meaning measuring different factors in the blood, such as antibodies, antigens, cytokines, using method called the gold standard called ELISA, where, for example, in this 96, we can test about 40 duplicate samples for certain antibody. We can go all the way to 384 determinations. The color development is proportional to the level of the antibody. Then the ELISA reader is going to read that and convert that to a number, which then we are going to analyze the data and try to correlate that with cell-mediated immunity. In the case of cellular immunology, we can take a drop of blood and based on more than 350 different cluster differentiations on the surface of lymphocytes, we can stain different lymphocytes using monoclonal antibodies to different colors. The flow cytometer is going to separate them. The computer is going to count them with high accuracy and report them as a percentage and total number of T cells, B cells, Th1, Th2, Treg, NK cell, and so forth. Now, if we take the data from humoral immunity, integrate that with cell-mediated immunity, we can correlate that with patient symptomatology and develop a better treatment modality for that specific patient. So this is the beauty of systems immunology. So one of the most important biomarker of humoral immunity is looking at gut permeability. This is one of those patents was awarded to me in 2015, but earlier version of this test was developed in 1998, and another patent was given to me in the year 2000. And that was about measuring intestinal barrier function. And this is the improved version of it, where we measure at Cyrex, we measure antibodies against bacterial toxins, actomycin, occludin zonulin, and elevation in these antibodies against these antigens may indicate gut permeability, epithelial cell damage, tight junction damage, and very interestingly, when some of these biomarkers are abnormal, almost 70% probability if an individual is suffering from leaky gut, that individual also is going to suffer from leaky blood-brain barriers. Most of Dr. Karazian, in a very interesting article, Dr. Karazian looked at more than 200 blood samples of patients where Cyrex did array 2 by looking at occludin zonulin and LPS antibodies. They classified the test results to two. One group, they did not have positivity in level of these antibodies, meaning they did not suffer from intestinal permeability. The second group, the antibodies were highly elevated, meaning they did suffer from intestinal permeability. When analyzed the data for possible autoimmunity by doing array 5 multiple autoimmune reactivity screen, they found that significant positive linear correlation between serum occludin zonulin antibodies and circulating autoantibodies against human tissue, which is indication of possible development of autoimmune disease in the future. And this correlation was, when they did logistic regression analysis, there was 3 to 30-fold increase in the odds of detecting elevated autoimmune target protein antibodies in subjects with intestinal permeability compared to those who did not have problem with intestinal permeability. So this shows that when the gate is open, probability of development of autoimmunity is very high. And here's some examples. When they looked at fibrillin and arthritic peptide, which these antibodies are detected in patients with arthritis and osteoarthritis, we see huge difference between the blue is those with no leaky gut, and the red is individual with leaky gut. So individuals with leaky gut, all 4 cases, had much higher levels of antibodies against fibrillin, against arthritic peptide, against parietal cell, ASCA and ANCA, which are involved in Crohn's and ulcerative colitis. Years before that, myself with Dr. Karazian, also we found correlation between lipopolysaccharide antibodies in patients with Crohn and ulcerative colitis when the ASCA and ANCA was positive. So we see almost direct correlation between leaky gut and leaky blood-brain barriers with possible autoimmune disease in the future. The next question that I'm asking as part of the systems immunology is what, in addition to genes, what are the factors can affect our gut microbiome that can result in breakdown into tight junction proteins, which results in leaky gut syndrome? The answer to that is right here. Dietary components, which we are going to talk about, toxic chemicals, and infections. When it comes to testing, for example, for gluten sensitivity, celiac disease, non-celiac gluten sensitivity, many years ago, I came to this conclusion. If we have so many proteins in wheat, why laboratories measuring antibodies only against one component of it, which is alpha gliadin, right here? The same question I asked, if we have so many transglutaminases enzymes in the gut, why we are measuring antibodies against one? And so I developed this test almost 15 years ago, patented by myself and Cyrex laboratories. So let me repeat the statement I made earlier about measuring a broad range of immunological assays can increase the predictability of the immune system. So when we test antibodies against repertoire of proteins, in this case, proteins of wheat, we increase the probability of detecting abnormalities that we cannot detect them by measuring only antibodies against one antigen. So by measuring antibodies against these repertoires, we can find whether or not the patient is having celiac disease with high accuracy, whether the patient is suffering from non-celiac gluten sensitivity, whether or not the patient is reacting to meat glue or microbial transglutaminase in green, whether or not the patient just having autoimmunity against the enzymes such as transglutaminases, and whether or not the patient may suffer from dermatitis herpetiformis, skin autoimmunity, or the patient may suffer gluten ataxia, transglutaminase 6. Furthermore, we published this in the Journal of Cereal Sciences, but furthermore, because we have shown that gluten and other wheat proteins cross-react with many other foods, we have to test also against cross-reactive foods. For example, alpha casein, beta casein, casomorphin, milk butyrophylline, and others such as corn, millet, oats, rice, whey protein. Because if the patient is reacting to gluten, we don't test for cross-reactive foods and will not remove the cross-reactive food from the diet of that individual. Probability of that individual will develop neuroautoimmune disorder is extremely high. And this article was published in Proceedings National Academy of Science. As you can see, antibody made against casein cross-react with myelin-associated glycoprotein, which is involved in multiple sclerosis. Yes, we have to also test for cross-reactive foods. Furthermore, for additional foods that Cyrex is testing, Cyrex is the only laboratory that tests for food. If we consume that food in a raw form, measures antibody against raw antigens extracted from raw food. If we consume that food in the form of cooked, we extract antigens from cooked form of that food and we measure antibody against that. If we consume the food in the form of cooked and raw, we measure antibodies against both. If we don't do that, probability of getting false positive and false negative is extremely high. Furthermore, Cyrex measuring antibodies against gums, food colorings, proteins in the oils called oleosins, many lectins and agglutinins, enzymes, and many others. So that was about the role of foods that may play a role in some autoimmune disorders due to cross-reactivity and why measurements of antibodies against repertoire of antigens and cross-reactive food is very important. The second item which contributes to autoimmunity are chemicals. And these are the major 12 chemicals that you can see in here that have the capacity to, after getting exposed to them, when they enter into the human blood, can form neoantigen, meaning chemicals bind to human tissue antigens. And our immune system is going to react to the chemical plus the tissue that bound to, resulting in autoimmunity. So aflatoxin, formaldehyde, isocyanate, binding protein, cosmetics, heavy metals, and more are the major chemicals that form new antigens that at Cyrex we measure antibody against them. Also, I'm going to repeat one more time the statement, why is it important to measure antibodies against broad range of antigens, because that can increase the predictability of the immune system. So here, in relation to pathogens, at Cyrex, we measure antibodies against 29 different infectious agents who have a capacity to cross-react with human tissue, contributing to autoimmune disease. Example, Yersinia enterocolitica cross-react with thyroid-specific antigens, therefore contributes to thyroid autoimmunity. Campylobacter jejuni cross-react with ganglioside, which is involved in Guillain-Barré syndrome. Candida albicans cross-react with Saccharomyces, which we think is involved in Crohn's, but it is Candida that is responsible for induction of Crohn's. The same thing all other pathogens mentioned in here, chlamydia, mycoplasma, acinetobacter, Klebsiella, mycobacterium, molds, citron-related EBV, which is involved in rheumatoid arthritis and also in thyroiditis. And finally, HHV6, Borrelia, Babesia, Ehrlichia, and Bartonella. All of these have the capacity to induce autoimmune disease in human. And therefore, it is important to measure antibodies against the repertoire of infectious agents and their antigens shown in here. Now, because food, toxic chemicals, and pathogens can also affect our microbiome, inducing leaky gut. When the gate is open, unwanted antigens can get into the circulation. We make antibody against them, and those antibodies can turn against our tissue, resulting in autoimmunity. That's exactly what Dr. Karazian did. He looked at patient with leaky gut, and then he measured antibodies against all these 24 tissue antigens and found direct correlation between leaky gut versus multiple autoimmune reactivity screen. So the message is that if you want to prevent autoimmunity, you better take care of the gut barriers. And finally, when we look at the Alzheimer's links, in addition to measuring antibodies against brain proteins, growth factors, enteric nerve, also we measure, or Cyrex measures, antibody against pathogens, chemicals, foods, and blood-brain barriers. So this is the kind of panel I highly recommend that to consider for your patients, not just for Alzheimer's, just for screening purposes. So that was my introduction about the importance of measuring biomarkers of humoral immunity with emphasis on the gut barriers as well as multiple autoimmune reactivity screen. For cell-mediated immunity, the method which we are using at Cyrex called flow cytometry. So flow cytometry allows us to examine the relationships among immune cell populations and find changes in their patterns that correlate with clinical findings. So immune prints of an individual correlate with clinical findings. And what in here that all these cells are measured at Cyrex by using flow cytometry. Abnormalities at the cellular levels can correlate with overactivation of the immune system, inflammation, autoimmunities, allergies, asthma, hypersensitivities, and cancer. So we measure not only white blood cell and total lymphocytes, but we look at T cells, B cells, the ratio, T helper cells, cytotoxic T cell, the ratio, CD4, CD8 ratio, T helper 1, T helper 2, the ratio between T helper 1 and T helper 2, regulatory T cell, T helper 17 and the ratio. And finally, we look at different natural killer cells and cytotoxic T cells and the hybrid between natural killer cells and cytotoxic T cell. If you want to read about 7 important cells that protecting us against microorganism and cancer, please read this article. Was published only yesterday in the journal called Microorganisms, and it is available online. The slides associated with this article are, I'm not going to present them, but I included them at the end of the presentation for those who will be interested to review them. But I decided to just select one figure from that article because it shows the importance of cell-mediated immunity, both in the induction and prevention of autoimmune disease, including long COVID, myalgic encephalitis, and chronic fatigue syndrome. So in some individuals, after exposure to SARS-CoV-2, unfortunately, they do not get rid of the SARS-CoV-2. We call that viral persistence. This viral persistence causing reactivation of EBV and HHV6 or latent viruses. So now SARS-CoV-2, EBV, and HHV6 release so many antigens, so persistent antigenic stimulation, causing generation of autoreactive lymphocyte T helper 1 and T helper 17. At the same time, the body also expands the number of KIR positive CD8 positive T cells. So now, because T helper 1 and T helper 17 are autoreactive lymphocyte, meaning have the capacity to attack our tissue, depends on degree of their autoreactivity. If their autoreactivity is weak, the viral is going to be cleared from the system. But if the autoreactivity is strong, but the KIR positive CD8 T cell can suppress the activity of these Th1 and Th17, also prevent autoimmunity by regulating the immune system and back to immune health. But unfortunately, if KIR positive CD8 positive cells will not be able to regulate the immune system and prevent strong autoreactivity, then the end result is going to be long COVID, myalgic encephalomyelitis, and autoimmunity. So I just included one slide in here about possible treatment modalities for these kind of abnormalities. Definitely, it is highly recommended to put these patients on low-fat diet, low sugar diet, because high sugar changing our gut microbiome, low salt because salt is changing T helper 17 autoreactive lymphocyte, and yeast product also increasing the number of autoreactive lymphocytes, and the references are right here, and recommended high fiber diet in order to empower the power of our regulatory T cell in order to prevent autoimmune disease. So with that, I would like to present to you 2 different cases, which the doctors used both measurements of humoral and cell-mediated immunity in their diagnosis. So this is a patient with mast cell activation syndrome. So mast cell activation syndrome is a heterogeneous disorder with recurrent symptoms typical of mast cell activation with increased release of mediators such as histamine and leukotrienes. Of course, patients lose tolerance mechanisms to environmental factors. That's why develop something like multiple chemical sensitivity. Exposure to environmental factors induce mast cell activation at the epithelial borders, resulting in leaky gut and its associated immune dysregulation and possible autoimmunities. Currently, there is no reliable blood test for mast cell activation since it occurs at the epithelial border. So here, the 64-year-old Caucasian, 5'4", Caucasian woman, 5'4", 110 pounds, with history of allergy to shellfish, molds, and grasses. Unknowingly ingested moldy tuna. In less than an hour, she developed constellation of hypersensitivity illnesses consistent with the diagnosis of mast cell activation. She was put on antihistamine medication and improved significantly. However, episodes repeated on weekly basis without finding the real cause. So as a result, she could not tolerate many foods, including even fruits and vegetables. And because of this, in the past 12 months, she lost 30 pounds and now weighs only 80 pounds. She became extremely sick and has been going from doctor to doctor with no resolution. So finally, one of the doctors ordered LMAP, lymphocyte MAP, from Cyrex, and the following abnormalities were detected. Number 1, low white blood cell count. Number 2, high percent lymphocyte. Relatively high T cell, and therefore that results in high T and B cell ratio. But one of the most important abnormalities that is associated with mast cell activation is T helper 2, both percentage and absolute numbers are very high. Furthermore, this patient not only is having high Th2, but is having low regulatory T cell. So that confirms that the patient indeed suffering from mast cell activation. Of course, there are some abnormalities at the level of natural killer cells, which indicates absolute immune dysregulation. So after confirming mast cell activation syndrome with LMAP, the ordering doctor first recommended that the patient avoiding environmental triggers known to initiate mast cell. For example, exposure to chemicals, infections, wrong foods, stress, and many more. He also treated her with H1 and H2 blockers, mast cell stabilizers, leukotrienes inhibitors, and aspirin. After 2 weeks, symptoms seemed to be under control as long as she avoided the triggers. So here we see that LMAP helped the doctor to design treatment modalities for patients with mast cell activation syndrome. The second case is a patient with thyroid autoimmunity due to EBV reactivation. So here, 58-year-old female with brain fog, short-term memory, fatigue, insomnia, chronic neck pain, previous diagnosis of Hashimoto's, EBV reactivation, and she was vaccinated with COVID. And after vaccination, the vaccination caused an increase in all her thyroid abnormalities and symptoms associated with that. And then the doctor ordered array 2, looking at the gut, autoimmunity, array 7X, neuroautoimmunity, looked at the food, looked at blood-brain barriers, and finally looked at Alzheimer's links. The first test of leaky gut was ordered in October 2020, significant abnormalities. So therefore, this patient with thyroid autoimmunity had significant abnormalities at the level of leaky gut. Please look at second test, which was done in June 2022. After treating the patient with leaky gut, the patient's results completely went back to normal. Furthermore, when he did array 20, the first test, June 2021, was highly abnormal. After treating for leaky gut, the blood-brain barriers also was repaired, and therefore the antibodies against blood-brain barrier went back to normal. Doing multiple autoimmune reactivity screen, please look specifically thyroid peroxidase antibody. We are not surprised because the patient was suffering from thyroid autoimmunity. He knew that. The doctor knew that. But also what we found that patient had antibody against synapsin, which maybe that could be associated with neuroautoimmunity, brain fog, and other symptoms that the patient was suffering. At the immunosciences lab, also, we did the classical autoimmune panel, negative anti-nuclear antibody, negative ENA, negative double-stranded DNA, negative rheumatoid factor, but immune complexes were elevated, which indicates significant presence of inflammation, antibody against actin, and mitochondrial antibodies, meaning the patient was in the process of growing additional autoimmune disease, in this case, probably liver autoimmunity. IgM antibody was measured against synapsin and was elevated, which confirms the first test. Finally, when the first test was done for viral antibodies, significant elevation in viral capsid antigen was detected, followed by early antigen elevation, and then antibody against herpes 1 and 2 as well, IgM. When the patient was treated for Epstein-Barr virus, please look at second test. The VCA antibodies disappeared or went down from 8 something to 3 point something. Early antigen from 1.8 to 1.3, meaning it's not completely resolved, but other biomarkers went back to normal. So we know that Epstein-Barr virus is involved in more than 30 different autoimmune diseases. Some of them are shown in here. Yes, thyroid autoimmunity, liver autoimmunity, and many others that you see in here. So therefore, in patients with autoimmunity, thyroid autoimmunity, other autoimmunities, we should measure titers of antibodies against Epstein-Barr virus, including viral capsid antigen, early antigen, and Epstein-Barr nuclear antigen as well. Now, the doctor ordered also LMAP. And these LMAP, as you can see, were done twice, 2021, 2023. White blood cell counts and lymphocytes were low, some improvement in the second test. Total B cells are low. Okay? The percentages in here is low. Therefore, T and B cell ratio is high because the patterns is affecting each other. But the most impressive number in here is when we look at CD4 CD8 ratio, meaning high CD4, low CD8, resulting in high CD4 CD8 ratio, which is found specifically in patients with different autoimmune diseases. And when CD4 is elevated, obviously either Th1 is going to be elevated or Th2. And in this case, we see definitely the number of Th1 were elevated significantly. And then finally, we see because Th1 is elevated can affect also the number of T helper 17 and calculation of the ratio. In relation to natural killer cells, we did at that time were not doing all these natural killer cells. In the second test, we see the patient also was suffering from low number of natural killer cells, and therefore the capacity to get rid of pathogen probably is not very good in this particular case, unless we are going to empower the natural killer cells in order to be able to kill the viral infected cells, in this case, Epstein-Barr virus, EBV infected cell. So the patient was treated with thyroid medication, and many of patients' chief complaints have resolved since treating her leaky gut and blood-brain barriers. And the doctor says that I have targeted her EBV reactivation and supported her WBC, but have not seen a real or significant changes in her lymphocyte panel. There was some improvement. Her brain fog and fatigue are the most persistent complaints. And again, because we have seen elevation in synapsin or neurologic antibodies. So the question was asked, where do we go from here? And the answer to that is because EBV is not being eradicated completely. Early antigen still is IgG against early antigen still elevated, which indicates reactivation of latent viruses, in this case EBV. We have to deal with that. Deal with low lymphocytes, white blood cells, by giving natural anti-inflammatories for elevated CD4 CD8 ratio. Maybe it's a good idea also to increase the number of CD8s, because by increasing the number of CD8, by giving low doses of DHEA, such as 5 milligrams, by increasing number of CD8, we can bring the ratio of CD4 CD8 down, for example, from 6 or 7 to 3 or 4. And then finally, we need to increase the number and activity of natural killer cells, because natural killer cells are going to destroy viral infected cells, in this case, Epstein-Barr virus. How can we do that? vitamin C between 500 to 1000 milligram a day, mushrooms, AHCC, astragalus, and many more. And in conclusion, the essential barrier panel and comprehensive lymphocyte map should be major components of systems immunology examinations. Obtain results, carry interpretable information that may connect abnormalities to the role of exposome, such as food, toxic chemicals, and pathogens in induction of inflammatory and autoimmune disorders. Finally, predictable human immunology holds implications for better diagnostics and curative precision in patients with infectious and immune-associated disease. That is direct quote from Dr. Forlin article, which was published in Trends in Immunology. I'm going to repeat that one more time. Predictable human immunology holds implications for better diagnostic and curative precision in patients with infectious and immune-associated diseases. And ladies and gentlemen, that is exactly what we do right now and what we started doing at Cyrex Laboratories started 2011. Thank you so much.
Hi, everyone. We hope you enjoyed this class. If you're a practitioner, make sure you go sign up at rupahealth.com. And if you like this video, don't forget to like and subscribe.